In this lecture, we'll be discussing the legal obligations for EMS. This lecture is very much going to expand upon the previous lectures, not just the legal aspects of EMS, but the patient-provider interactions, and going deeper into some of those. First thing I want to talk about is patient autonomy. Everybody has the right to make their own decisions. Even if you don't agree with those decisions, even if the patient's family doesn't agree with those decisions, as long as they are an adult and they have proved that they have competent decision-making abilities, they have the right to decide what happens to them, even if the outcome would be something that's less than desirable. That can be really tough sometimes and can put our ethics, especially our personal ethics, at not at risk, but at juxtaposition to what's going on with the patient. Because we're good patient advocates and we're trying to be good stewards of that relationship between us and our patients, you have to honor their decisions. You can try to talk to them about the impact of the decision they're making. So you get called to a patient, it's very obvious that they're having what could be a life-limiting medical emergency. You've noticed significant elevation on their 12 lead. They are definitely having an MI that you can interpret to the best of your ability. If they are above the age of 18 and they otherwise are showing that they are fully competent and their decision-making ability has not been impacted, they can refuse care and transport, even though the likelihood of them succumbing to what's going on with them, to their current medical emergency. If they don't want to be transported, that is their prerogative. You can talk to them about it, talk to them about the exact outcomes, make sure that they understand the outcomes. You can engage family, you can engage some type of physician to try to talk to them and persuade them into making another decision. But at the end of the day, if that is their wish, they have the right to direct their own care. And this doesn't have to just be refusing. And we talked about this in one of the previous lectures, if you've listened to that one so far, that they have the right to pick and choose what parts of their care they want to have utilized. So it might not be they're refusing transport, but they're refusing a medication you think they need. They're refusing another procedure that you've determined would be in their best interest. If they don't want it, they have the right to refuse that. You are backed by previous Supreme Court decisions and laws that are out there that if the patient has essentially been an informed consumer, they are aware of the risks of refusing that treatment and or all the way up to transport, you will not be held liable because they can make their own decisions. You can't force it upon them. This can conflict with not just your personal ethics, but also what your guidance and your guidelines are telling you to do. You need to very carefully document the interactions between you and your patient, and if at all possible, have one of their family members, a friend, somebody who is related to the patient, not to you. Even if it's not a familial tie, they're tied to the patient, not necessarily to you and to EMS, that is a part and aware of the conversations, and they need to witness that refusal statement. Show that you serve your full due diligence to talk the patient, persuade the patient into a different decision, that ultimately they are free to make whichever one they would like. Also, with patient autonomy, we need to make sure that our patient is getting the best care that we possibly can, but also that we're not inadvertently harming our patient. Part of this can happen when physicians issue orders and they may not be in the patient's best interest. So we encode. We are asking for guidance, or an MD, DO, some type of higher level provider happens to overhear our encode and they request that you do a procedure for the patient, you administer a certain medication for the patient. If it is something that you truly do not believe is in the patient's best interest, will ultimately cause harm to the patient. First, clarify that what you're interpreting or you're hearing them said is actually what they want to happen. So they're giving you a medication, but maybe the dose is inappropriately high, or just the wrong medication for this particular thing, to the best of your understanding and your knowledge. Once you confirm it, if the doctor did in fact say what you thought they said and you don't think that it would be in the patient's best interest, don't perform it. Document why. Discuss it with the MD, the DO, whoever it is over the radios to why you're concerned for the patient. Maybe they didn't hear fully what was going on with the patient. So that same STEMI patient earlier, you've talked them into going to the hospital. They've agreed, but they don't want any treatment. They just want to go to be evaluated. And the doctor overhears it and they say, no, you need to administer aspirin and nitroglycerin. And what they also missed was that your patient is profoundly hypotensive. So the aspirin wouldn't be contraindicated, but the nitro would be. Confirm that that's their order and then relay to them your concerns and why you think it wouldn't be in the patient's best interest. If they are still adamant that you administer that medication and you know that it will cause ultimate harm to your patient, withhold it, document why, and make sure your patient is aware of why you're withholding that. Be a good advocate for your patient, even if that means disagreeing with those around you. If you are always acting in your patient's best interest, you will rarely be led astray. Speaking of end-of-life decisions or things that can impact our patient, we're going to talk about advanced directives, living wills, DNRs, things along that for the next couple minutes. People, when they are fully aware and have good decision-making capacities, are able to decide what they would like their medical care and their end-of-life care make in the instance that they lose those decision-making capabilities, that they're no longer fully cognizant or competent enough to make those decisions per our definitions. Prior to that, they can elect in and out of certain things. These are very structured in the way that they're done, and they include living wills, do not resuscitate orders, also called DNRs. You'll see sometimes in the hospital or in other places, they don't call them DNRs necessarily anymore. They started referring to them as ANDs, to allow natural death. So just to not intervene, to allow the natural course of someone dying to proceed as it is. And then also organ donation is technically a type of advanced directive. It varies state by state as to what exactly EMS is allowed to adhere to and what we're allowed to honor. But the whole purpose of these is making sure that patients and people are able to decide their own destiny, to pick what they're comfortable with. And when these things are put into place, they tend to involve some type of doctor, so MD, DO, whoever the patient's seeing, the patient, the patient's family, and depending upon what it is, sometimes it also will involve lawyers and notary publics, people to make it like a very official document. In the state of South Carolina, we do honor valid DNRs. We do not necessarily honor advanced directives. However, if the patient's family tells you that they have an advanced directive, that they do want this, but they don't want that. So they maybe do want you to work them as a cardiac arrest, but they don't want to be intubated. You can relay that to the hospital and you can get online orders to not engage in certain procedures that would otherwise be required of you per your guidelines. It is a way that we can honor the patient's wishes, but still keep ourselves legally covered, if that makes sense. So ensuring that they are getting their wishes that they want. And this can also include certain types of comfort care. So where we see these tend to be elderly or people that have life-limiting diagnoses. There's some type of hospice patient. They have a medical condition that they know is ultimately going to lead to death. And they have had lots of discussions with their doctors, with their family, to decide what is best for them, what they're comfortable with, knowing that if they are resuscitated, that there's a very slim chance that one, that was going to happen in the first place, but two, they were going to have a quality of life that they're comfortable with on the back end. So they would rather not even chance that. They'd rather just let what's going to happen. That is not an easy decision to come by, and we need to make sure that we're doing everything we can to protect that was our patient's wishes. Living wills and their healthcare power of attorney. This is a type of advanced directive that we'll see in the field, and it does relate to that end of life medical care. So these are some of those. I will take this. I can be given this medicine, but not this one. So I'm okay with NSAIDs, but I don't want anything stronger. I don't want narcotics. That's a weak example, but it could be in there. I'm okay with basic airway procedures, but I don't want anything advanced. I don't want anything that's going to be inserted in. Where we see these are people who have been intubated in the past and were very difficult to near impossible to wean off. They don't want to go through that again. If they can be managed with basic maneuvers, they're okay with it, but they don't want anything more advanced than that. I am okay with medications to augment my heart rate, but I'm not okay with electrical procedures. So things where they can opt in and out. These can also include assigning a power of attorney. A power of attorney is the person who speaks on behalf of the patient when they've lost that decision-making capacity. Remembering that it's only when the patient has lost the decision-making capacity is extremely important. If you are on scene and patient is saying, I do not want to be transported to the hospital, they are above the age of 18, they have demonstrated to you that they have good decision-making capacity. They are fully competent, fully aware of what is going on, and they have answered and done everything for you to an acceptable level. But then a family member shows up and says, no, I am their power of attorney, you will take them. If that patient still has decision-making capacity and they have proven themselves to be competent, they get to decide what happens. That durable power of attorney only kicks in when that decision-making capacity has officially been lost or in moments when it is lost. So especially patients who have dementia, there may be times where they are cognizant enough that they can make their own decisions, but times when they are not. So then the power of attorney would kick in and they would make decisions on behalf of that patient. There are also different types of power of attorney. So if the patient does have a living will and you're able to see it, not all power of attorneys are authorized to make healthcare decisions. So a person could decide that this person can be a power of attorney on my financial grounds. They can make the money-making decisions. But this different person is going to be the one who makes my healthcare decisions. If you are on scene and there is like a family dispute going on about who gets to decide, you do whatever is in the patient's best interest. Apologize, deal with whatever backlash might be coming on the back end, but act in the patient's best interest. Go with what is best for the patient, and then everything else can be sorted out later. But we need to try to honor the patient and the power of attorney if we can figure out which one is making that decision. That surrogate decision maker is the person who wants full decision making capacity. So they are fully unconscious, they're vented in the hospital, they're trying to decide what to do with the patient. That's where that surrogate decision maker would come in. That's not always the power of attorney. Sometimes that's the spouse, sometimes that's somebody else. Again, full moral of this story though with the power of attorneys is act in the patient's best interest. When you're able to do what would be best for the patient, unless it's the patient telling you no. DNR orders. These we can adhere to in the state. It has to be one of the state DNR forms. It has to be valid, so all signatures must be there. They do expire, so it has to be one that is within date. Or it could be a bracelet, a DNR bracelet. It has to be from a company called Sticky J, but they are able to wear those. Tattoos that say DNR, DNRs that are damaged, DNRs that are expired, DNRs that are missing signatures are technically not valid. And we can talk about if troubleshooting and if you run into some of those situations, some of your options in just a second. But with that valid DNR, they are asking you to not resuscitate. What exactly resuscitation is not fully up to interpretation, but it slightly can be. So that does not mean do not do anything for the patient. If they are hypoxic, you can give them a little bit of oxygen. If they are in pain, you can absolutely give them pain medicine. If they're nauseous, you can give them Zofran. What it's asking you to do, though, is if they're declining and they are becoming peri-arrest or go into cardiac arrest, we do not intervene. We do not do anything that's going to be resuscitative for the patient. So while oxygen administration is okay, ventilation, positive pressure ventilation tends to not be, because it is sustaining their life. While giving pain management is okay, giving medications that would be considered resuscitative like epinephrine would not be. So clarifying anytime you run into a situation that you're unsure would be important. But when somebody is signed a DNR order, again, they tend to have a life-limiting illness, or they're of an age where they know that the likelihood of them having a good quality of life on the back end is extremely slim. If you have a patient who does not have a valid DNR, so it's expired, a signature is missing, something. If the family has damaged it before you got there, if they just can't find it, but family is telling you they have a DNR, technically, you are to work the arrest regardless. Even though it is said they had one, if family has damaged it, it's not valid anymore because it's not fully intact. If signatures are missing, it's expired. That's no longer a valid DNR. You're supposed to work the arrest. I encourage you, outside of the family has damaged it, that is a conversation to have with family. With the other circumstances and even with the family damaging it, try the best you can to honor the patient's wishes. The patient did not want to be resuscitated. You legally do still have to work the arrest. So what you can do is start working the arrest. Start doing the compressions, start doing the ventilations, going down that route. Encode med control or the hospital as soon as you can. Explain to them the situation that you're facing, that you're on scene with an X number year old patient. They are in cardiac arrest. Here's the history. Here's what family's telling you or what you've seen, and ask for orders to terminate. This would keep you from having to do what your full guidelines are telling you to do of working the cardiac arrest, and it's honoring the patient's wishes to the best of your ability while also still keeping you in a sound legal position. They did not want to be resuscitated. They wanted to have their last moments preserved. And think about from the family's perspective. So again, not the one where the family decided that they wanted to take fate into their own hands and they damaged the DNR, but they're telling you this patient didn't want to be resuscitated. They're trying to honor their loved one's wishes. And then we come in and we're doing CPR, which is very aggressive. We tend to be shoving things into their loved one, whether it's an IV, an IO, some type of supraglottic airway device, or intubating them. So we're putting all these things into them, and we're doing this very violent procedure to their loved one that did not want that. And instead of seeing their loved one peacefully drift off and enter into the afterlife and them get to spend those moments with them, they are seeing us do all of these very aggressive things, and that is going to be the last memory they have of their loved one. We want to try to avoid that for all beings involved. You still have to work the cardiac arrest until you can get those orders, but instead of working it for a prolonged amount of time and them seeing it for a prolonged amount of time, explain to them what's going on, that we have to engage med control. I have to do this in the meantime, but as soon as I find out, we can stop. It is very rare that a med control wouldn't say, sure, absolutely, honor what's there, honor their wishes, and stop. In the state of South Carolina, we can often run into this with pediatrics who have DNRs, especially around areas that have very large pediatric hospitals that have specialties, because these very sick, chronically ill, life-limiting ill patients will come to these areas for treatment. Their family is aware that they are not going to be here for a very long time. They don't want them worked. They don't want them to be resuscitated. Not because they don't want them to continue living, but because they know that it's not going to be a good quality of life if they even come back. So they just don't want to put them through that. Again, discussions that they have had at length with the doctors that are involved in the care, as well as other people within their lives, to come to that very difficult decision. We really don't have DNRs for children in this state. If you encounter a child and that's what parents telling you, encode as quickly as possible. Do the same thing. Start working the cardiac arrest, explain to the family why you have to, and then get med control on the phone, on the radio, as soon as you can to get those orders. When we're withholding or withdrawing resuscitation, this can be one of the places outside of DNRs where we could potentially open ourselves up to not just litigation, but difficult moments on scene with family, with whomever that may be there. Withholding resuscitation or withdrawing resuscitation should not be something that's taken lightly. True, if somebody is already in cardiac arrest, they're technically already dead, but there's still that chance that they could be resuscitated. There's still that chance that this isn't truly the end of their life. So when we make that decision, we have that judgment that this cardiac arrest is not viable. We need to take that very seriously. The National Association of EMS Physicians has recently published, within the last couple years, guidance on when it is appropriate to terminate resuscitation in non-traumatic arrests. What we do know from that research is that the best chance the patient has at being resuscitated is on scene. As soon as we start moving the patient, we start packaging them, we start working them in the back of the truck, we drastically diminish the chance of viability. And that's because of the delays that are caused. And we just cannot do as good a quality compressions when we're in the back of a moving ambulance. Because of that, they really should live or die exactly where they're lying. We should work that cardiac arrest where they're going to get the best chance at survivability, which is where we found them. Once we can get them into a nice open area where we can have room to work, that is where the cardiac arrest should be worked. There's also time limits. So if they have had good quality compressions, good quality CPR, with or without ALS interventions being utilized, once we reach 20 to 25 minutes of resuscitation, it is very unlikely that they're going to be resuscitated. And that if they are, they're going to have a good quality of life on the back end. Around that time, looking at your guidelines is when you could start considering. The state laws here do not preclude you from terminating on scene with or without medical control engagement. We will talk about it in resuscitation chapters, and your guidelines at your services will have very clear, these are the markers we want you to meet to terminate on scene without calling med control, versus calling med control whenever you think that the patient does not have good chances, but you haven't clearly met those markers that your services laid out quite yet. There are times where we would not begin resuscitation at all, or that if we had just started, we would actually choose to stop. If we notice that it is actually a trauma patient and they have massive blunt trauma to the point that this is looking like they probably went into cardiac arrest due to exsanguination, things like cardiac tamponades, something where we are not going to be able to resuscitate them on scene, you can consider transporting more quickly or encoding to terminate those efforts. People who went into traumatic arrest secondary to exsanguination, we're not giving, for the most part, whole blood products on scene, or enough, if we are giving whole blood products, to fully replenish what was lost. It is very unlikely that they're going to be resuscitated at all. Once you find that there are signs incompatible with life during your resuscitation, so you or somebody else quickly started compressions. As you're getting on scene and you're doing more assessment, you notice that they do have some rigor that's formed in the jaw or starting to form. You're now seeing signs of dependent lividity as you're able to start assessing the patient. You go to manage their airway and you're noticing gross deformities that would allude you to the idea that they have not life limiting, but life terminating circumstances. They're not compatible with life anymore. You can stop the resuscitation. To cover you from the legal aspect, you can encode and make sure that med control is on board with your decisions. But that is something that can happen. When we are looking at the ones that tend to be the most difficult for us to terminate on scene, and it is pretty rare to get med control to agree with you and allow you to terminate on scene. It is pediatric patients that are otherwise healthy. So not the ones that have chronic life-limiting illnesses, but ones that it was some type of accident that led them to be in the situation. Everybody wants to give the pediatric patient the best chance. It's that gut reaction of they haven't lived a full life. I need to give them the chance we can. And so we tend to work those cardiac arrests much longer than we would normally think of them as being viable. Med control has a really hard time giving us orders to terminate those patients on scene because they also want to be able to say and know, not just from the legal, but from that, like, my soul, from my ethical stance. I want to give them the best chance I can. You then have the added pressure of family on scene. They are having a lot of the very same feelings that we are, that is, they are gone too soon. It can be very difficult reconciling your medical knowledge and your training and those personal feelings about it. If you do not feel comfortable terminating on scene, transport to the hospital. Transport to the hospital, let them engage all of their resources, and then everybody collectively can make a decision. Again, if you are doing what is in the patient's best interest to the best of your ability and your knowledge, you will rarely be wrong. This last slide and what we're going to round up talking about is really just the summation of everything that's been talked about in this lecture. Those end-of-life decisions. We often, being in pre-hospital medicine or inter-facility medicine, discharges to home, we'll see patients at the end of their life that they have been dealing or battling whatever illness it is for an unknown amount of time to us most of the time. And they are in that twilight time. They are approaching the end. Patients are aware that that's happening. That does not mean that they don't deserve every bit of respect and empathy that we can possibly give them. We should treat them just like every other patient. They deserve the best of us regardless. We shouldn't question their reasoning for making the decisions that they've made. We can encourage them and give them all the information to be informed from our standpoint and from what we can do for them. But at the end of the day, just because they're approaching the end of their life does not mean that they are not competent and that they don't deserve the same rights as everybody else, which is to make their own medical decision. When we encounter situations where their decision conflicts with our morals or what we truly feel is best for them, they are still allowed to be the ones to make their decision on their behalf. We do not get to take that from them. That can be difficult. That can cause us to feel some sort of way. However, it is not our body. It is not our choice to make. It is their choice to make. They are fully able to make any decision that they would like. They have to be informed about that decision, but they can still hold it and they can still make it. When you do have patients that have these PULSE, so physician order or medical order for life-sustaining treatment, this is that a la carte. They can pick what's done and what's not done. I want to be intubated. I don't want to be intubated. I want this medicine. I don't want that medicine. I don't want feeding tubes. I do want feeding tubes. While not all of that applies to us pre-hospital, we unfortunately cannot honor any of it in this state without engaging medical control. If they have that or they have expressed that to you, encode and let them know what's happening, get that backing, or carefully document within your chart why you did or did not do something for this patient. Organ donation. We can see on if they're a South Carolina driver, if they have that little heart that they would like to be a part of organ donation. There's this rumor going around online for a couple years that paramedics would not work somebody if they saw that heart so that their body could be used for organ donation. And that is the weirdest and most disgusting thing that I've ever heard. No, that is not a reason to withhold resuscitative efforts, but it's also not a reason to resuscitate somebody. Ignore that. If somebody could be a candidate for organ donation and you are working them on scene and you want to transport a little bit sooner, okay. But that should never be something that's in the forefront of our mind. There are types of medicine, and as a paramedic, you may eventually go into organ donation and transport of organs. And that's cool. There are a variety of, oh my goodness, I'm so sorry. There are a variety of different types of organs that they can harvest to be donated. And full disclosure from my knowledge in working in a hospital, even if somebody has said, yes, I do want to donate my organs, the family still gets called and gets to decide on the back end, at least in this state and in this area. I've heard and seen many of those phone calls. If you have questions, please do not hesitate to reach out to your instructor.